If you are starting on the wards this month, someone has already drilled the Sepsis 6 into you. 6 things, 1 hour. Good, it saves lives. But here's the uncomfortable part for all of you. The version most of us memorized is actually out of date, and one of its steps, done the old way, can actually harm your patients. I'm going to give you the Sepsis 6, the way it's actually meant to be, especially in 2026. The framework, the memory hook that's worked for me for over 15 years now, the three things that quietly changed, and how the UK Sepsis 6 relates to the international bundle you'll see in exams. So let's go. Here's the plan for the next 15 to 20 minutes. First, when does the clock actually start? Because the Sepsis 6 is only as good as your recognition. Then the bundle itself, three things you take and three things you give inside the first hour. I'll give you a memory hook which actually has survived the guidelines since I first wrote it back in, I would say, 2010. It has been over 15 years now, or 16 years. Then the three steps in the 2026 guidelines for surviving sepsis campaign, which quietly changed: oxygen, fluids, and antibiotic timing. And finally, the things that exams love to test, for example, MRCP and USMLE exams, and how the UK Sepsis 6 actually relates to the international 1 hour bundle. This is a misconception, both are not exactly the same. Same goal, but two different tools. When to activate Sepsis 6 resuscitation bundle? And the Sepsis 6 actually starts with recognition, not a lab test. It's not a typical investigation that you can rely on, just like a one off test. So, step one: is there a suspected or confirmed infection? Ask yourself. This is the basic question. And remember the definition of sepsis, which I've covered in multiple sepsis modules. The videos are available on the YouTube channel. The sepsis definition is that it's a life threatening organ dysfunction caused by a dysregulated response to infection. So basically, we're not talking about the infection itself, it's the host response of the organ dysfunction, which is not regulated, it's dysregulated, not just the infection itself. So that's the first step. Step two: screen properly. The 2026 Surviving Sepsis Campaign, AU, gold standard, recognizes and makes a strong recommendation to use an early warning score like News 2, which is available almost in every hospital in the UK, or similar tool like Muse or SIRS over qSOFA. Because qSOFA misses too many patients on its own, and qSOFA is not a screening test, it's more of an out of ICU mortality in patients with sepsis. And step number three, you need to recognize and identify the red flags as soon as possible in a patient with possible sepsis or severe sepsis or septic shock. I mean, severe sepsis is not a terminology used anymore. It used to be back in prior to 2026 guidelines. So the red flags would be new onset of confusion, a systolic blood pressure of less than 90 millimeters mercury, if the patient is tachypneic with a respiratory rate of 25 or more, and if the patient is requiring supplemental oxygen to maintain oxygen saturations, or serum lactate is 2 or above, and the urine output is tailing off, or the patient has mottled non-blanching skin. All these signs are suggesting hypoperfusion, hypotension, and hemodynamic compromise and circulatory collapse. So please watch out at the bottom. The key thing that I have just flagged in this slide is that qSOFA is specific but not a sensitive marker. So a normal qSOFA does not rule out sepsis, and do not wait for it to become positive before you can act. The Sepsis 6 at a glance, the key slide here. This is the whole bundle on one screen. You take three, you give three. So the three things that you take from the patient are the blood cultures, serum lactate, and urine output. And instead, in what you give, the three things that you give back are oxygen, IV antibiotics, and IV fluids. And all six inside the first hour of recognizing sepsis. So that's the key thing. Now, one thing worth noticing is that this Sepsis 6 is a UK Sepsis Trust tool. They distilled it from the much larger Surviving Sepsis Campaign guidelines into a very practical memorable and easily achievable and deliverable tool for a busy team who have multiple patients to be seen, and so that they can actually deliver a reliable and standard bedside tool on a daily basis. So please remember, it's not a rival to the international guidance. It's a practical, operational or operationalized version of the same. We'll come back to this distinction at the end, because the exams, the MRCP, USMLE, they love this type of question. Now, in practice, all these steps actually happen simultaneously, but it has been made memorable of take three and give three, so that you can easily remember the six particular tools. And that's why I have developed my own mnemonic, which I'm going to share shortly. So here it is, my mnemonic, then and now. I built it in 2010, but it still holds true with a slight change. This is really personal to me. Years ago, back in 2010, when I was at the start of my higher specialist training, ST3 onwards in acute medicine and general medicine in the Northern Deanery, I was working at New Cumberland Hospital, Whitehaven, and as part of one of the requirements for the CCT in acute medicine, I had to do one extra subspecialty skill, and I opted for medical education certificate and then postgraduate diploma. So as part of the PG dip in medical education from Cardiff University, I chose Sepsis Six workbook. So I created a workbook for core medical trainees. It was a 68-page document as a PDF, which I submitted as a as an assignment, and it was graded with very high grades actually. So I came up with a mnemonic which still stands just like yesterday in my mind, and that is O, be aware of flu. Okay, OBAFLU. What does it mean? Oxygen, blood cultures, antibiotics, fluid challenge, lactate, and urine output. So OBAFLU, 6 steps. Now, the reason I love it is that the letters haven't changed at all. The framework has completely survived the guideline updates. But look at the first O. When I wrote it, I remember it was oxygen high flow for everyone, blanket. However, 15 liters non-rebreather at that time. Now in 2026, the single word is the biggest change in the whole of the bundle. So we titrate oxygen now because it's a drug. It has its own consequences and complications. You have to titrate according to the target situations and the patient need. So too much oxygen can have its own harms actually. So keep the mnemonic. Just update the thinking behind O, which means the letters are the same, but the medicine has grown up. And we can think of the Aurum AU, gold standard for this particular scenario. So let's look at the 3 steps each, the take 3 and the give 3. Take 3, the 3 things that you take are the diagnostics basically. They steer everything after that. So blood cultures, serum lactate, and urine output. So blood cultures, at least one set, and ideally before administering antibiotics, because antibiotics can lead to sterilization. It can lead to they can sterilize the blood culture sample within minutes, and hence it can cost you some extremely valuable information about the microbial pathogens. The other source, also if relevant, like urine samples or sputum or a line, if you're suspecting central line associated bloodstream infection, or even CSF. But the most important rule that matters is that never delay administration of antibiotics just to take cultures. If you can't get the blood cultures quickly, please give the antibiotics. This is in SSC 2026 guidelines as well. The second take is lactate, and any serum lactate of above 2 means there is tissue hypoperfusion, and a lactate of above 4 marks a very high risk patient, one of the red flags for such patients. Again, a VBG, a venous blood gas, is perfectly acceptable, because here you're looking at the acid-base balance and the lactate rather than oxygenation. I've covered in the ABG module of one of my videos about the differences between ABG and VBG. Now, you don't have to do only one VBG or one lactate. Basically, check it initially, and then you periodically assess for the effect, of the resuscitation on the patient's care. And the trend actually tells you whether the resuscitation is working or not. Now, in terms of the blood cultures, one other thing is, if you remember, with blood culture, you have to send full bloods, full blood count, renal function, liver function, coagulation profile, C-reactive protein, procalcitonin, send the full workup as appropriate according to patient's clinical situation. And lastly, what you take from the patient is the urine output. So you need to measure hourly urine output, catheterize if you really have to. The minimum target should be 0.5 milliliter per kilogram per hour. So in a standard 70 kilogram patient, you're talking about 30 to 35 ml per hour as a bare minimum urine output. The recommended range is 0.5 to 1, but minimum is 0.5 milliliters per kilogram. One other thing, in my experience when I was working in nephrology in Leicester during my training as ST3 LAT in renal medicine, is that the urine output actually doesn't match the fluid resuscitation or the blood pressure. Once you maintain the blood pressure, the urine output may take some time because the kidneys have to be perfused properly for a good amount of 4 to 6 hours in my understanding and in my experience. So that's why I do not think that once the MAP is maintained, the next minute the urine output will match, because kidneys need time to produce urine. So this is one practical tip actually. Now, if you can remember in the blood cultures, I did not deliberately say 2 sets of anaerobic bottles within 45 minutes. No, because the guideline doesn't specify taking the 2 sets of cultures. However, please follow your local guidelines, local policies as best as you can. And if you can send 2 sets, that is ideal. Now, coming to the Give 3. So this is where the guidelines in 2026 have moved. The 3 you give are based on the modern guidance. Number 1, oxygen. One size fits all, previous formula, it's now gone. Now you titrate according to the target saturations of 94 to 98% in most of the patients, and you have to use the scale 2 for patients who are COPD or anyone with risk of carbon dioxide retention and type 2 respiratory failure and hypercapnic respiratory failure. In those patients, the target will be 88 to 92%. This is a big change, not routine high flow for everyone, and that is important. Number 2, antibiotics, broad spectrum intravenous following your local policy. Give them immediately within the first hour, especially the stat dose, the initial dose. And for septic shock or when sepsis is probable or definite. Now, there is a slight nuance in 2026 guidelines that if the patient is generally at low risk of infection or without shock, then you can monitor and investigate. But obviously, for the sake of Sepsis 6, if you're suspecting sepsis, thinking sepsis, then obviously that will not apply. You are already working towards the Sepsis 6 guidelines or Sepsis 6 resuscitation bundle. Fluid balance or fluid resuscitation, you think of the balanced crystalloid like Hartmann's or plasma light. It's much more preferred over the normal saline, 0.9% saline, because of the risk of hyperchloremic metabolic acidosis due to too much chloride content in the normal saline. Again, you have to give boluses. The famous rule of 30 ml per kilogram over 3 hours is still suggested. People have a misunderstanding that it has changed. No, it's a start of a 4-phase, four-phase guideline of fluid resuscitation. The first step is 30 ml per kg, but then assess and reassess. It has to be a dynamic assessment based on patient's hemodynamic status, volume status, serum lactate, and trend, etc. So that's the key thing. Okay, so this is a very favorite slide of mine in this video. Sepsis 6 versus the 1 hour bundle. Both people confuse it because Sepsis 6 has to be given within 1 hour, and then people refer to the golden hour or the 1 hour bundle. So Sepsis 6 basically is for the UK purposes or UK recommendation, United Kingdom. But the 1 hour bundle is more of a global recommendation. However, both are pretty much on the same lines. Please remember that. So Sepsis 6, as I said, I developed my mnemonic, which I shared with you. O, be aware of flu. So O, B, A, F, L, U. This is the checklist: oxygen, blood cultures, antibiotics, fluid challenge, lactate, and urine output. It's operational. You take 3, you give 3 within the first hour, done. Deliverable by any ward team. Usually they have sepsis resuscitation bundles printed out or in the EHR, electronic health records, etc. And these have been audited. Now, the Surviving Sepsis Campaign Global, the 1 hour bundle is an international evidence score, and it wants you to measure and remeasure lactate. Make sure you take blood cultures before antibiotics, and initiate broad spectrum antibiotics as soon as possible, giving crystalloids for hypotension and a lactate of 4 or more. Or if it's rising despite fluid resuscitation, you have to give vasopressors and to keep the maintain above the target of 65 millimeters of mercury. Now, this is the elegant part. If you watch what happens, look at my mnemonic, OBA flu, OB aware of flu. So if you keep the middle four, the core four components, those four are still in the global SSC 1 hour bundle. So oxygen and urine output, if you just take them out of the OBA flu, you have blood culture, antibiotic, fluids, and lactate. And instead of the urine output, you can add VEED for vasopressors. Or if you just want to stick to BAFL, FL is fluid and lactate regarding blood pressure. And if the lactate is still rising and despite fluid resuscitation, so F and L are linked, then you can think of vasopressors. So that's another way of remembering it. But please remember that oxygen and the urine output, they have not been removed from the sepsis guidelines at all. This is just to keep it simple for the 4 core components in the first hour. You still have to give oxygen as appropriate. You still have to monitor urine output. So please do not consider that it's only 4 things. Yes, the 4 things are priority in the first hour, the golden hour, but oxygen and urine output will still be part of the overall sepsis resuscitation. For clinical exams and the ward pearls, 7 quick pearls. These are the ones which can catch any doctor and they can also turn up in exams. Number 1, blood cultures before antibiotics, but never delay administration of antibiotics just to get the blood cultures. Number 2, oxygen is titrated, not a 15-liter non-rebreathing mask for everyone. 88 to 92% for COPD patients or hypercapnic risk patients. Number 3, 30 ml per kg fluid resuscitation is the starting point of a 4-step model, not a fixed mandate. I've covered this in the fluid resuscitation module and the sepsis 2026 guidelines introduction module or the video on my website. And number 4, screening tool for news using news tool rather than a qSOFA. qSOFA is specific but not a sensitive marker. And number 5, please know that the sepsis 3 definition of septic shock, you need vasopressors to keep the MAP at 65 and above and a lactate above 2 despite adequate fluid resuscitation. Now both criteria have to be met for it to be septic shock. Lastly, number 6 point is that Sepsis 6 is not the same as the Surviving Sepsis Campaign bundle, the UK bedside tool versus international evidence set, although both are derived from the same core components. Number 7, antibiotics within 1 hour is the firmest in shock or high likelihood of sepsis. For low risk patients, you can observe, monitor, but in majority of patients or when in doubt, administer antibiotic as soon as possible, and please follow your local policies and guidelines. 1 hour, 6 steps. O, be aware of flu. Oxygen, blood cultures, antibiotics, fluids, lactate, and urine output. Or take 3 and give 3. The 3 things which changed in 2026, titrated oxygen, number 1, rather than blind oxygen. Giving balanced crystalloids and reassessing after every bolus, dynamic reassessment is really crucial. And the antibiotic urgency following the patient's risk. And do not delay administration of antibiotics just because you want to take blood cultures. But if you can take blood cultures before antibiotics, that's ideal. That's really, really good. So if you want to have deep dive behind each of these guidelines and the 5-step changes which occurred in 2026, on screen, I've got a full comprehensive series on sepsis 2026 guidelines, including screening, fluids, antibiotics, vasopressors, and de-escalation. The last 2 episodes are going to come soon, but 4 modules are already live on YouTube. So please subscribe, and I'll see you in the next one.